Hey, Anna. Oh, everyone's coming in. There's Danielle. Hey, Christy. How are we all doing?
Doing good. Can you hear me?
Yeah. Hey, Danielle.
Hi, how are you?
Oh,
Good. Excited for this. I don't know how many people are going to show up.
Oh my gosh, no worries. I'm like just seeing, I just signed up for this new thing, this Fryer AI is supposed to help with my email. And I'm like, I guess it naturally comes and takes notes too. So I don't have
Oh,
the
yeah. We have something like that, like a Fathom note taker, but it takes notes of
Yes.
all the whole call, and then it will like use AI and like summarize it and like all that. So,
Yeah.
yeah,
I was using I forget the other one. I was using another one like that too. They're great.
they are. They are. Hi, Christine. I saw her. She just signed on. But yeah, we will be recording this to send out to the other ladies. I
Perfect.
definitely a few people that messaged me and they were like, I can't make it, but I want to watch it, which I
No, that's fine. That's perfect.
so yeah, thank you guys for being here. I'm getting barked at. This is Danielle. She is a nurse practitioner. She's local here on the South Shore, and I don't even know how we got connected, but I've been working with her for a few months now with the HRT stuff. I started the testosterone injections. I don't know if you guys know the whole story, but tried the cream. It was kind of a disaster. So found Danielle and doing the shots, which are going well. And then we added in some oral progesterone, and that's been going well. I was just telling her the other day, I've been sleeping great. I always say that's like my flex is now that I can sleep. It's
That's
like,
like usually the first thing all women say is like, thank you for the sleep.
like everything sucks if you don't sleep, like bad mood, you want sugar,
All
you're
of it.
hungry. Hey, Caroline.
Hey.
But sleep is like the thing. So, anyways, but over here at Carrots and Cake, we don't do the bioidentical hormones to the level that Danielle does. So I wanted to connect you guys and just know what this is all about because it can be super helpful as far as just getting you to the next level. And as I always say, you guys have done many, many great things with Carrots and Cake, maybe run some testing, all of that. But the hormones are not coming back. They're just not. We're just on the decline. So you can add them back in and it helps you feel better. And there's so many benefits. And I think that's exactly what Danielle is going to talk about today is just all the scary stuff that we may have heard over the years. A lot of it's wrong. And there's a lot of, research that just was not interpreted the right way and all of that. So I'm going to stop talking. I'll let Danielle introduce
Oh,
herself and, take it from here. And, she'll stay on for questions at the end.
awesome. Thank you so much. Thanks so much for having me too. So first and foremost, I definitely want to hit upon, so obviously the work that you guys do with Carrots and Cake, that is a huge piece. I always think a lot of times women come to me and they have symptoms. And again, I look at hormonal health as part of foundational health, especially as we begin aging. But part of that foundational health is like diet and lifestyle. So that is hands down one of the things I always encourage. So a lot of times you can't fix everything with hormones, but they do a lot. Um, that being said, real quick intro. My name is Danielle. I'm a nurse practitioner. I've been in healthcare now for like 25 plus years. In the last 3 or 4 years, kind of specializing in hormone replacement therapy, but have done functional medicine for the last 10. Kind of dived in a little bit with the hormones when perimenopause hit me smack in the face. And it definitely kind of hit me for a whirlwind, wasn't expecting it. But it really was the precipice of like what made me dive into the research and understand it. Because when hormones were offered to me, I think I had the very common response that most women do of like, whoa, I don't know if I want to take hormones. They seem risky. They sound dangerous. That's something that I've always been told. And it couldn't be further from the truth. Um, so that being said, I'm a huge proponent for hormone replacement, not just for symptom management, not for sexual health, but as primary prevention. And to me, a lot of times, one of the biggest questions I get from some women are, I don't have any symptoms, or I don't have hot flashes, or I think I sleep okay. Um, and my answer to that is I'm jealous. Good for you. But two, I think one of the biggest things too is like once you start learning the role in which hormones play throughout our whole body and on every single cell, you start realizing how important it is to maintain that hormonal health. And it doesn't mean bringing you up to where you were when you're in your teens, but at the same time, having a certain level will help maintain big things, such as cardiovascular disease, probably the #1 killer in women, especially after the age of 60. Huge correlation there when we start seeing our hormones take a nosedive. And usually by the average age of menopause is 51. So 60 is usually around the time that women have been about 10 to 15 years without hormones. And we start to see huge dysfunction in a myriad of places in our endothelial lining. That's the lining that's all throughout our cardiovascular system. That is the metabolically active part of our cardiovascular system that creates nitric oxide, helps with that dilation and restriction to help control our blood pressure. So we start seeing hypertension, high cholesterol. And that primarily comes from estrogen, but there's progesterone too, and that's another one. So one of the other things I feel like women always think, especially if they don't have their uterus anymore, that they don't need to take progesterone. Obviously, estrogen and progesterone have a symbiotic relationship, and how I try to explain it is estrogen is what makes the grass grow, and progesterone is what mows it down. And that analogy usually works primarily for when we think of like endometrial lining, and then also breast tissue. So a lot of times when women have really heavy periods or they have really heavy, dense breast tissue, that's kind of like an estrogen dominant symptom. Obviously, again, adding in progesterone will help balance those things out. But even progesterone has other huge major health factors for women. So obviously, Tina was talking about her sleep when she first started here. um, this is probably the #1 complaint that I usually start getting from women who are perimenopausal. And I don't know if I should like kind of give like a high up of like, physiologically what happens during perimenopause, but perimenopause can be anywhere from like 5 years, 7 years to even 10 years. And so when we look at the average age of menopause being 51, perimenopause could start at even 35 for some women. I personally, myself, I am 47, I am menopausal, and I think my doctors did not believe me for a long time. But looking back now, probably around age 35, 36, I definitely started to feel symptoms, and I didn't know. But what happens in perimenopause is our ovaries, we have a certain lifespan, if you will, and the primary hormones that come from our ovaries are progesterone and testosterone. And yes, women need testosterone. We are definitely going to dive into that. Um, so what happens is as we start entering perimenopause, it slowly declines the health of our ovaries, the amount of eggs that we create, but then also to the hormones that it produces. So progesterone and testosterone kind of have like a steady nosedive for like a good 7 to 10 years. And then during that time, because our ovaries no longer are releasing eggs as well as they used to, or producing those follicles, we start having really erratic levels of estrogen, meaning our brain is asking our ovaries to spit or create more follicles, and sometimes the ovaries can't keep up. But by the brain spitting out more FSH, what happens is we start getting these huge spikes of estrogen and then these huge declines. Now, when we have this super erratic levels of estrogen and then unopposed by progesterone as it kind of slowly declines, that's where we start getting some of those horrible symptoms. A lot of women will start having anxiety, heart palpitations, insomnia. Some people will start losing their hair. That's another common one. They start seeing like a really rapid reduction in skin elasticity, meaning they're showing like more wrinkles. And that's a lot of times due to the decline in testosterone, believe it or not. So testosterone will unfortunately also too why sometimes it can cause acne, but it does help increase your sebaceous glands and its oil production. So some women will start to see, once you replace it, like better skin, glowier skin, less wrinkles. But a lot of times during that perimenopausal phase, we start to see a lot of these symptoms come on. Now, because women also have receptors throughout our whole body, and one of the things I think I love the most about hormone replacement is, I've always like in functional health, we really focus on mitochondrial health. Like I think when you think of like cellular health, and I think a lot of your work, Tina, really does focus on that too, right? Um, we have receptors on our mitochondria for all 3 hormones. So what happens when we lose those hormones and those receptors are still upregulated but not bound to, it actually creates a inflammatory response, but then also too metabolically at that mitochondrial level, they're not functioning as well. And it actually starts increasing macrophages, which then down the line starts creating this like low-lying inflammatory process. So a lot of times I feel like we hear things like, oh, it's an inflammatory process, or I feel bloated or whatever, but it's kind of sometimes true. At a very minute level, but it starts affecting everything upstream. So perimenopause, it usually hits women between the ages of like anywhere from like 35 to 45. But if I'm being honest, it kind of can happen anywhere. That's why I really like taking the individualized approach and looking at symptoms, labs, and kind of correlating everything together. Um, but the other thing that I feel that people don't understand, and the hormone more in particular for women, is testosterone. So one of the things a lot of times women will also come to me is that they're just not feeling like themselves. There was actually a journal article, and they've now dubbed that a diagnosis of I don't feel like myself. To me, that's almost like a sad thing to accept that now we're just going to give that a diagnosis of that. And a lot of times, unfortunately, women are then offered antidepressants, anti-anxiety medications, things like that, which, by the way, I am not saying there is a time and place for those things. I am not totally opposed to them. However, a lot of times I can speak from my own experience practicing in primary care for so long. I feel as though I don't want to say training, but I guess it was training, but when we would have meetings about with the medical team or the medical director, we would talk about trends that we would see in patient visits, et cetera. And one of them was women in this age group, anywhere between 40 and 60, with depression, anxiety, weight gain, fatigue, brain fog. And I was trained to be an empathetic listener, to empathize with them, explain to them that's part of aging, to give them support with a therapist like cognitive behavioral therapy, to give them resources, obviously explain to them the importance of diet and exercise, um, which all is important. I'm not saying those don't have a time or place, but then we would review the SSRIs, we would review side effects of those medications, and like that was like the next step for that woman. Um, you know, I personally, when I started entering that phase, I did go through my primary care and I was offered other things. And I remember sitting there being like, I know this song and dance, man. I was trained in it, but I kind of did follow it. And unfortunately, it just wasn't what was missing. And I just remember, having this moment of not feeling like myself. And I share this story a lot with people, not because like I don't think everyone has the same experience. But to me, it was just so profound. I do remember a point like in my journey where I was like, you know what, I need to feel alive. I need to feel something. And I was like, chocolate will do it. So I went into my pantry and I got a piece of chocolate and I put it in my mouth. And sure enough, like my body didn't even know how to emote to the fact that I had chocolate in my mouth. And I remember sitting there in the pantry being like, well, if chocolate's not going to do it, is this what I'm going to feel for the rest of my life? Because this is awful. Like it was just flat. And that was really what to me was like, there's something else going on, much more deeper and I've been very fortunate. I've never had experiences with like severe depression or anxiety or anything like that. So I consider myself very fortunate, but I do believe I probably experienced the beginning stages of that. So that's where I took the deep dive. And one of the bigger ones, in particular is, estrogen. So estrogen actually acts like a SSRI. It does help increase the reactivity of serotonin in our body. So it actually helps improve serotonin. So if you look at how SSRIs work, they actually bind to the serotonin receptor so that we can reuptake more serotonin. So we have more free serotonin floating around. And that's exactly how estrogen works, but naturally. So it's not uncommon for women when they have these super labile ups and downs, or like, and again, these ups and downs do steadily trend downwards, to start having depression. Another thing that women will have a lot of times is that underlying feeling of just like that short fuse. Like you just wake up, it's like you haven't even seen your family yet, and they're already like annoying you. So that a lot of times is progesterone. So progesterone is our chill pill. So progesterone, especially if you take it orally, it will break down into a metabolite called allopregnanolone. Allopregnanolone does then bind to our GABA receptors. So GABA receptors are our chill pill receptors in our brain. If we think about medications that actually work on those, that is something like Ativan, Xanax, any of the benzodiazepines. Now, obviously, progesterone isn't as strong as those, but a lot of times once women start introducing progesterone again, you kind of turn that volume down on that underlying just like short fuse feeling. Women sleep amazingly. It also helps really well for brain fog. It's very neuroprotective. In the acute care setting, some patients, if they have strokes or traumatic brain injuries, we will give them high dose IV progesterone because it is that protective and it helps with that neuroplasticity and recircuiting. So that's another thing. It also has anti-inflammatory properties. So that's a huge thing. The other thing is it helps support thyroid function and metabolism. I always hesitate to kind of share some of these things because I just know for myself and anecdotally, like I think sometimes as women, I don't think it's unhealthy to be concerned about our weight, but I always hesitate to share as that it can help with metabolism. It does help in the sense that it can help regulate how we're going to metabolize some of our fat lipids, along with it supporting the thyroid, especially in the liver, converting T4 to T3. So when we start losing that, we lose the ability for our own conversion. And that's hugely important. Sometimes it can help too with bloating and water retention. Unfortunately, sometimes too, women take it and it does cause that a little bit in the beginning. But it helps maintain skin elasticity, collagen production, can even help with hair regrowth. Again, super common for women in perimenopause to start seeing hair loss. Sometimes I look at it as like a twofold, probably the loss of progesterone and also the decrease in conversion of T3. So again, a hugely important piece of replacing that. The other thing, again, we talked about testosterone. So the big one here for women is, I think it's the dialogue is out there more now about testosterone in women and how it's common. I think myself 10 years ago when it was offered to me, I kind of was like, pump the brakes. I have no idea what you're talking about. Well, they're like, you don't want to have sex, right? I'm like, no, I don't. And they're like, well, that's a symptom. But I guess I think I wasn't as familiar with the fact that women actually have more testosterone than estrogen. And again, I had to educate myself. I love that the dialogue is out there. I'm like, I zone out on Instagram every night, but I love that we're seeing women actually sharing that they're on it. And I will say anecdotally for myself and in my patients, to me, that is the hormone that ends up like putting the icing on the cake. It is usually what we start to see where that light comes back on. So testosterone really works by improving dopamine. So if we think about what dopamine does, that's our go-getter. So that's the one that's a feel-good one. If we think about Adderall, that's the brain chemical that improves upon for focus, mental clarity. We do see a huge increase in women being diagnosed with ADHD between the ages of 40 and 60. That's not uncommon. Again, I'm not saying that it's not a time and place for medication, but maybe those medications work better if your testosterone and your hormones were optimized. The other thing it does too is it improves brain health. So it is a neurosteroid and it helps with inflammation. It helps maintain, like we talked about that, the healthy appearance of your skin and things like that. But definitely helps with reducing symptoms of depression or low mood. I personally can speak to that. That is one of the things I think kind of blew my mind. I didn't have like high expectations, I guess. But like 2 weeks in, it was one of those moments where music felt good again. Like you could feel the music. You could like when you go out in the sunshine, you were like, oh, it's a beautiful day. Because I was like losing that. And it was like so sad. The other thing, so this is the only thing that it is actually FDA approved for, and this is in the US, is for low libido. So it's the diagnosis code is hyposexual desire disorder. However, here's the kicker. We don't have any FDA approved medication or testosterone for women in the US. So there is a FDA approved indication for it. Some prescribers will use the male version, which is called androgel. So it's at a much higher concentration than what a female would have. And you just kind of eyeball it, or you can pull it up in a syringe. The downside to it is one, you're guessing. It's really hard to kind of fine tune the dosing. But the other thing is it's alcohol based. So women do best if you're going to use the cream to apply it to your labia. So our labia actually has a huge proportion of our androgen receptors, but also too, if we're using it for the indication of hyposexual desire disorder or low libido, what happens is obviously, yes, we're kind of adding it right at the source, but it helps with increasing blood flow to the clitoris, but increases our orgasm quality. But secondarily, again, for that primary prevention, it actually helps with maintaining the vaginal tissue and integrity. And that becomes so huge. So there's another thing called genitourinary syndrome of menopause. That is something that is kind of all encompassing. Again, hyposexual desire disorder kind of falls under that umbrella, but some of the other ones are urinary incontinence, painful urination, recurrent UTIs, pain during intercourse, vaginal itching or burning, pelvic pain, vaginal dryness. Those are all encompassed. So one of the things, and again, I don't know if I have any Rachel Rubin fans out there, but I'm like a huge fan of her. I know, right? So she's really spearheaded the whole urological standpoint for vaginal estradiol, which I start all my patients on, hopefully prophylactically, because it becomes so, so important. So as we lose our hormones, testosterone included, but especially estrogen, we start to see a decrease in that tissue integrity. And if we go back to like where we were talking about those receptors and they're all throughout our body, we in particular obviously have a ton throughout our vaginal canal. But what happens is because estrogen, I think it's the alpha receptors that are responsible for that glucose metabolism. When we start losing glucose metabolism in our vaginal canal, we end up losing our ability to maintain lactobacilli. When lactobacilli goes down, our pH goes up, which then becomes a more favorable environment for bacteria. That coupled with now the fact that we're starting to lose tissue integrity, it becomes thinner, more friable. I don't know if I have any medical providers out there, but if you know what friable means, it means that tissue is really easy to break through and bleed. It's very, what's the word I'm looking for? Very thin, I guess. And then the other thing too is we have the receptors along our urethra, but also in our bladder. So when we lose that ability for our bladder to actually contract as well as it used to and empty fully. So then we have that residual urine that then stays there. And I kind of liken it to a dirty fishbowl, but then we also have that inability to maintain a healthy urinary tract anymore because we're loss of pH. And we're just setting ourselves up for recurrent UTIs. I can tell you right now, when I worked in urgent care, we would see women between 60 and 70 and 80 with recurrent UTIs all the time. And they'd be like, I just don't even know what to do anymore. I get them every 3 months. The downside is those will continue to happen. Unfortunately, antibiotic overuse, you end up becoming less susceptible to some of the antibiotics. And eventually what happens is urosepsis, completely avoidable. And I think Rachel Rubin's work says it's by 73%, we can reduce mortality rates. 73%. That's insane to me. I don't think there's a drug out there, procedure out there that has anything like that. And that's literally just by replacing vaginal estradiol. One of the things that's really awesome about that too is it only works locally, vaginally in the tissues. It does not go systemically because obviously the dose is extremely small. Eventually you don't use it as frequently. It's extremely safe. The breast cancer organization actually just released a statement, I think it was like a week or two ago, about the importance of vaginal estradiol in breast cancer patients and the importance of that, not only for quality of life, but even for long-term outcomes. So super, super important. The other thing that becomes in, menopause and perimenopause is called the musculoskeletal syndrome of menopause. So that's another huge thing. So a lot of times women will start talking about they have a lot of joint pain. They feel like they have like almost like fibromyalgia, like they just feel like they have pain all over. That was a symptom I was starting to have that I thought was super bizarre. I remember turning to my sister, being like, "Were you ever so tired where like your body hurts and you feel shaky?" And she was like, "No, never." Now, mind you, she's much younger than me, and maybe it's coming. I don't know. But I just remember it didn't matter what I did, if I was eating healthy, training well, sleeping well. I mean, it was like as if my body was just giving up on me. But 70% of women will experience musculoskeletal symptoms, and 25% of them will end up being disabled from them through that transmission of perimenopause and menopause. Again, these are often unrecognized symptoms, by the medical group in general or conventional medicine. But like most of the ones that we can think of is like osteoporosis, sarcopenia, tendinopathy, carpal tunnel, frozen shoulder. So this is actually something usually like in the PT world and orthopedic world, it is actually recognized in menopausal women. It's a true thing that happens where it's like an adhesive capsulitis where you're no longer able to lift your arm up past a certain amount, completely treatable with estrogen. Fibromyalgia, low back pain. And again, all of these things go on and on. Another one is plantar fasciitis. That's a big one. Obviously, I feel like this one is a real common one that everyone's familiar with, but osteoporosis. One of the things I feel like, again, I don't know if I have any Peter Attia fans out there, but I always feel like there is medicine 2.0, he always calls it, and then there's medicine 3.0. So I like to think I'm on medicine 3.0's team. Um, but osteoporosis, we always look at bone density, meaning like how thick is that bone mineral? What no one looks at is that tensile tension. Like we want hard bones, right? But we don't want them so hard like a crystal so that when they fall, it just shatters. We want it to be able, like a barbell under a load of weight, to like bend and be able to handle that. So that elasticity comes from this collagenous, matrix that's also due to estrogen and testosterone. So two main things that are so important. Again, progesterone plays a small role, but testosterone and estrogen. So we want to have those strong, dense bones, but we also need them to bend under stress. Hugely, hugely important. Um, the other thing too, is brain health. So, Dr. Lisa Mosconi, I think she's the one who's more or less spearheading most of the research right now in this, which thank God we need a lot of research in women's health. But with I guess the correlation, although I want to say causation, because I think her research is headed that way, but the correlation with the loss of estrogen and the increased risk for Alzheimer's. So one of the things I think that has been a theory for a long time is that when we went through the menopausal change and women were not on HRT, that these receptors kind of turned off and they just kind of went to bed. And that was like the natural phase of life. And that was what was supposed to happen. Through Dr. Lisa Mosconi's work, she's shown quite the opposite. So what she found was that women who are not on HRT and went through that menopausal phase and 5-10 years out on these brain scans, she noticed that they're now having an increase of these estrogen receptors turning on, meaning your body is really smart. It does amazing things. Our body starts creating more receptors and turning more of them on because they are reaching for any tiny bit of estrogen they can possibly get. So what her research is really showing is that your brain needs estrogen. It is starving for it. So what she's also found is that women who are on HRT, we don't see that upregulation because everyone's able to like uptake it because if they have it systemically, but we're also seeing an improvement in white matter, which becomes so important when we start looking at Alzheimer's. One of the theories too is like Alzheimer's happens in women because we lose estrogen. An average 70-year-old man will have more estrogen than a woman 70 years old and not on HRT. So that to me is wild. Again, more research has come out to be like direct causation, but I think it's safe to say we kind of know. So obviously those are kind of some of the primary prevention pieces that I think are super important, even outside of symptom management. But one of the things I always find, and this is probably I'm going to try and hit upon some of the more common questions I get during my discovery calls is, are they safe? My mom had breast cancer. I don't want to have breast cancer. Or my sister has breast cancer. Or I'm BRCA positive. Does that mean I can't have it? So a lot of that fear came from the Women's Health Initiative. So the Women's Health Initiative in 2002 was actually a really good study, but unfortunately the findings were misreported, and sadly so. And I don't know why they've never gone back or redacted some of the statements. I will say some of the primary investigators of that have kind of come publicly, but again, nothing has really been redacted. That being said, the limitations, and I'm going to read from the study, but the limitations from the trial only tested one drug regimen, and that was oral conjugated equine estrogen. So that is from the horse's urine. It is synthetic. It is not considered bioidentical, plus medroxyprogesterone acetate. And I want to make sure I kind of highlight the medroxyprogesterone acetate. So this is a synthetic form of progesterone. This is the one that over and over and over again in several trials have been attributed to a higher risk of blood clots, a higher risk of stroke, a higher risk of cardiovascular disease or events. It is not the bioidentical one. But the limitations that even the Women's Health Initiative literally said, it remains possible that transdermal estradiol with bioidentical progesterone, which more closely mimics the normal physiology and metabolism of endogenous sex hormones, may provide a different risk-benefit profile. That is probably the $1 million statement right there. So the Women's Health Initiative did bring on, I think I forget how many women, it's like 200,000. I think it's still going on with like close to 30,000. But that being said, there were also some really good health outcomes. And that was even using the unhealthy forms of the hormones, which women don't use, or I'm sorry, providers don't use. If they are offering you that, they probably aren't well versed. But in the arm that used just the conjugated equine, so that's a synthetic estrogen, we saw 11% reduction in cardiovascular disease. Cardiovascular disease is the #1 killer in women over the age of 60. So that's wild to me that this study that kind of deemed that hormone replacement was so awful, but 11% decreased risk there. We also saw a 26% decreased risk in diabetes. Again, that's huge. That's massively important. All fractures were 16%, all-cause mortality was 11. So obviously we start seeing less of the improvements in the arm in the conjugated equine and the medroxyprogestate. And again, these are the hormones that honestly, both orally, I do not recommend. I would never prescribe them. But I do think it's super important to understand that. If anything, from the Women's Health Initiative, I think we could obviously glean that there are some obvious health benefits to hormone replacement therapy. Um, I do think the thing too that was kind of gleaned from that was that whole fear around using hormone replacement therapy and increasing your risk for breast cancer. Um, you know, Women's Health Initiative, their publications, they acknowledge that hormone replacement as the most effective treatment for managing menopausal vasomotor symptoms. But it actually does reduce the risk when you redo the data the right way, by 23%, by reducing breast cancer death by 40%. So there's something in science sometimes called data digging. So if you don't come out with the outcomes that you wanted, you can kind of fudge with the numbers. So this data was taken from Dr. Avram Blooming. And there was two other observational studies that redid the data as I guess you normally would. And those are the numbers that they came up with by reducing breast cancer by 23% and reducing breast cancer death by 40%. Even with the data that they shared, it was like, I think 1 woman in every 1,000 that were or increased the diagnosis of breast cancer, but the types of breast cancer that they had were less aggressive and their outcomes were better. And that's been shown with bioidentical hormone replacement therapy in quite a few studies, even out of Norway. One of the other things I think that people don't know, and this is something I feel like women should also share with their providers, is the American Heart Association in 2020 released a statement declaring that early onset of hormone replacement therapy is beneficial for reducing cardiovascular risk. So that to me is huge. The whole AHA completely supports the start of hormone replacement therapy as a primary prevention, not secondary. And there's 2 studies that I can think of outside of the Women's Health Initiative. Women's Health Initiative is probably one of the biggest ones, but there is the HART study and the HERS study. So both of these studies took women who were either perimenopausal, menopausal within that transition, within that 2 to 3 year before and after, and then also postmenopausal. They selected women who they knew had coronary heart disease. So what that means is they're already aware that they have either plaques in their coronary arteries, they've had events, they've had scannings or a calcium score, and it obviously was negative. So those were the ones who were selected. So the idea behind both of these studies was to see if adding in hormone replacement therapy, the bioidentical forms would reverse cardiovascular disease, because I think that was one of the bigger questions. And one of the things they found was the arm that had no hormone replacement therapy, their disease progressed as we normally would assume that we've normally seen. And that's even with medication being well managed on lipids, statins, etc. The the arm that started HRT early, meaning within that 10-year window, had no progression of their disease. It remained stable. The arm that started HRT late, meaning past the age of 65, and this is in women who have a known cardiovascular disease already, that one also did continue on and progressed. So there was no like reversal, if you will. Again, this is a small subset of women. I don't think most women have this. I do not think that it's unsafe for women past 65 and older to stay on hormone replacement therapy or start it. But what I will say that the best part of these studies did show was that obviously the effects on prevention for cardiovascular disease outweigh any medication you could possibly put someone on. These were women who were also not really strict with diet and lifestyle as well. I think they were given guidance, but they weren't really followed as far as like making sure that they were what's the word I'm looking for? Adherent to it. So this was literally just in essence, kind of the only variable would be the addition of hormone replacement therapy. So again, I think it's just amazing. And especially when we start looking at what it does for that endothelial lining with that nitric oxide as well. The other thing too is like there definitely is guidance out there. So say for example, you're someone, you're already 65, say you're on, a few medications for your blood pressure, a statin for your cholesterol, but your numbers are controlled, right? So your blood pressure is controlled, your lipids are controlled, and there's even some things you can look in your labs in particular to really kind of parse out your true cardiovascular risk. And there's even some diagnostic studies you could do, like a calcium score. I think it's something, if your provider doesn't want to order it for you preventatively, they're usually around $200 or $400. You can get an order and then just kind of cash pay if it's something you wanted. But what that does, it's like a CT angiogram. So it looks at a CT scan of your heart and will tell you if you actually have plaques in your coronary arteries. But all that being said, as long as most of those things are controlled, meaning your blood pressure is within a certain range, your labs are within a certain range, it is 100% safe to do HRT. The Menopause Society actually even just released a statement, I think it was like 2 months ago, about the continuation of hormone replacement therapy beyond this 10-year window theory. I don't know if anyone's heard that before, but it kind of came from the two studies I just referenced, the Heart study and the HER study, where there was no benefit of staying on or became unsafe to stay on hormone replacement therapy past the age of 65. And again, it was because these studies chose women who had this and started them late. Obviously, like I do have a handful of women who do kind of fall under that category where they could questionably have some, heart disease or coronary heart disease. That is something that obviously you kind of approach uniquely. There are things, like I said, we do the CT angiograms, we'll do those all the time to see, like, really assess. And as long as you're working with someone who knows what they're looking for and going low and slow with the hormones, I think it's entirely safe. And obviously you have to constantly reassess risk versus benefit, annually or biannually, I think is the most important thing as well. Again, also that coupled with diet and lifestyle, I think it's really going only to add. I've yet to have anyone tell me they feel awful on them. Trying to think if there's anything else that I can really think of right now. Tina, can you think of any questions, or do you have any questions from the group that maybe I can hit upon?
If you
anyone
have questions, definitely jump in or throw them in the chat. But I would say, like, what would be like the first steps maybe to like figuring out like if this is something you should do? I know you talked about the symptoms, but like where do you go first, I guess?
Yeah, that's a great question. So that's another thing I feel like is super controversial, whether or not you have to test blood for it or get your hormone levels tested. To me, it's a resounding yes. So obviously when you work with someone, most of the time when you're doing hormone replacement therapy, you are treating to symptom abatement. So a lot of times it does take a little bit of nuanced understanding of like, which hormones would be responsible for what symptoms and starting there. But the huge benefit for me in getting your hormones tested, and I personally work with blood labs. I don't do saliva, and I take that back. I do use the Dutch test in certain situations, but I don't use that as a baseline. The reason why it's super helpful is because once I start someone on a regimen, like say, for example, a topical cream, um, it's really great to see if they're actually absorbing it. And it's so funny. You would think that there would be something that you could pinpoint in particular, like say it's somebody's body weight or, their fat content that would like inhibit or improve absorption. I cannot figure it out because it really is just so individualized. I have some women that do wonderful on the patch and their estrogen goes through the roof and they feel great. I have other women who the cream is the only thing that's getting through to them. And there's just, unfortunately, that's just how it is. Very commonly, or I should say pretty commonly, I'll try and use sublingual estradiol. So estrogen, one of the things, and this is a true thing, whether it's bioidentical or the conjugated. Now, mind you, conjugated, this is a higher risk piece that happens, but with the bioidentical, when you take oral estrogen, there are a ton of other benefits that you get more so for the cardiovascular piece. But the downside is that when you take oral estrogen, it does go through the liver through what's called the first pass. And the metabolite from that first pass is what increases our clotting factors. So say, for example, you were someone who's either had blood clots before, your factor V, or, protein C or protein S deficiency. Those would be people probably I wouldn't want to do any of the oral estrogen with or sublingual even. But in other people, sublingual is amazing. And usually that's the one I go to anyway. It's just you dissolve it under your tongue. It bypasses the liver. Some will still go through the liver. So I don't want to say it doesn't at all. But most of it's going to be absorbed through your mucous membranes there. And really women feel the best on that one for sure. But yeah, as far as testing and stuff like that, I definitely think there's a huge benefit. The other thing too is I do think it's important to get some of these advanced like cardiolipid panels done, knowing what your lipo-A is, ApoB, seeing what your CRP levels are. CRP is extremely important too. Your B12, your vitamin D. I know you guys do a ton of testing with like the mineral testing, which is huge because that kind of shows you how your body can utilize vitamin D, or where in that system or cascade it's maybe kind of junked up. So maybe it's not ideal to have systemic vitamin D and maybe need to work on your calcium or vitamin K, right? So there's a ton of different things that I kind of look at. But the thyroid, a huge piece too, because everything's connected, especially through that whole HPT axis, is your thyroid. So a lot of times, I like to call it like, well, it's not me in particular, but the world within I work with calls it, but it's subclinical hypothyroidism. It's where women have a harder time converting T4 to T3, or maybe their T3 is just suboptimal. A lot of times when women's T3 is low, meaning to me 3.3, 3.5 or below, usually I want to see them 3.8 to 4.5, somewhere between there. That's where someone's going to feel their best. That brain fog, that depression list, along with other things too, but they usually feel their absolute best there for sure. Trying to think how else people could start. A lot of times I usually do encourage patients to try and talk to their primary care or their OBGYN. I'm not going to try and I know, I know,
Who knows how that will go?
I
I don't want to
exactly.
interrupt you, but what do you think about those like online companies that do the hormones? Like MIDI and like all those.
Yeah, so great question. So I've actually tested MIDI myself. So MIDI did not want to do any labs. They definitely
Yeah.
MIDI, I think is great for kind of if you want to use your insurance. I think they overconfidently say that you can use your insurance because it's not something and one of the things I would probably encourage people to do if you want to go through insurance, which I encourage people to do all the time, would be to call your insurance company first, see what's on formulary, meaning either the estradiol patch, progesterone, prometrium is the other name for it. That's the bioidentical form you can get through your commercial pharmacies, because a lot of times it may not be on formulary. And I guess in my mind, if you're going to end up having to pay money for that, you might be better off going through a company that does use compounding, a reputable compounding pharmacy, because the quality is going to be much, much better. The patch usually compounding will not make. They are going to sell like the commercial version, but they will have other options. Like I said, the sublingual estradiol, that's not commercial. Estrogen cream, you can get that. There's also vaginal rings that you can use commercially. But as far as like midi goes, I think it's worthwhile trying. I do think they are reaching a service. I know there's another group too, Respin. I think that's Halle Berry's company. I think they also do go through insurance and stuff like that. I'm not totally opposed to it. I think Joy Wellness is another one that has a pretty good reputation. I personally kind of like their medical director, Amy Billiken. She's really great and kind of forward thinking. Um, a lot of times, my one hesitation is I think there's a huge difference between hormone replacement and hormone optimization. So you're going to see those two phrases kind of used interconnectively, but there's kind of huge differences. I like to think I do hormone optimization, meaning I'm not just going to bring you to the lowest level, although I'm not going to make you super physiological. I'm not in that world either. But really, we're going to take your level. And again, I'm not chasing a specific number to where you feel your absolute best. There are some companies like MIDI, I think will kind of, once a woman is within that quest range of testosterone. So say, for example, they're free testosterone. I don't even know if they even do testosterone, if I'm being totally honest. Because I know I was a patient of theirs and like they kept pushing my appointment to do my testosterone. And I was like, I don't think they have someone. Um, so that being said, a lot of times people will kind of follow those like lab ranges. So one thing I will say, women do feel better way outside of those lab ranges that you're going to see on your like Quest or LabCorp results. Usually we're going to see women in like 150, sometimes 200 on their free testosterone, and that's normal. I'm not getting surprised by that. The only time I'm ever alerted by that is like if someone's having side effects, right? A lot of times women will have side effects of like hair growth. Sometimes they'll like think that you will not grow a mustache at these levels, but acne is a very common one, unfortunately. But yeah, I'm a huge fan of some of the online things. Obviously, I'm a huge fan of Sparq Health.
Well, yeah, it was more like the big company, you know what I
Yes.
mean? Like faceless. Like obviously
Yeah.
recommend people to you, but yeah, I've just had like a lot of clients ask and I'm like, I don't know. I mean, I tried to
Yeah.
go through Heva Health, HEVA, and they did the whole blood workup and everything and my testosterone came back, single digits. And I got on a call with this like older doctor. It was a male, and I asked him about the testosterone. He's like, "You don't need it." And I was like, okay, this is
Oh,
the
weird.
company for me. And he was from Massachusetts, So I don't know if there's different rules in Massachusetts as far as the testosterone, but he shut me down real quick. And
Yeah. I mean,
yeah.
I think, yeah, that's crazy. So I will say, unfortunately, I mean, it's definitely an industry that's flooded. Like I know some really big ones. I actually know some of the founders personally, like Merrick Health. That
Oh
was
yeah,
one.
I've heard of that one.
Yeah. So that one kind of grew. So Transcend is another one too. And I don't want to say I know the founders of Transcend, but I kind of know people who do know them. So that being said, I think there are some companies that have like a real impersonal touch. I think they're kind of hitting a certain demographic. I will say those are probably the ones that are looking for more performance enhancement,
Yeah.
meaning maybe in the bodybuilding phase, but also to kind of really looking at I'm going to use the word biohacking. I don't know how else to say it, but they're ready to like inject themselves with everything and anything that someone will legally prescribe them with. So unfortunately, there are those, and I think there's a different approach. Again, it's a fine line between hormone optimization and kind of tilting into that world of like, maybe you're experimenting with chemicals too much for too many other things. But I think if you're looking more for like a personalized touch, I would definitely say, Joy Wellness. I think that's a really good one. Respin is another huge, big company with a really good reputation. They have a really great scientific board as well. Alloy is another one. That's a great one. So that has, I don't think Dr. Rachel Rubin is, but it's, what's her name? Dr. Men. I think it's Jen Omen. But anyway, Dr. Men. So she's a two-time breast cancer survivor, and she's a huge proponent for HRT for women who have survived breast cancer.
Right.
Um, so she's a wealth of knowledge along with Kelly Casperson. So she's also on their scientific board. And again, these are like really big companies that are probably covered in all 50 states. I think they do insurance. My understanding is that they do, or they could be concierge. I don't remember. But the ones that where you're not seeing a face, if you're not seeing someone, one of the things I would say, you know, I'm going to say this kind of lightly, but I feel like it's, definitely a sign that someone's invested in the education on this. But if you find someone who's a menopause certified provider, that to me is some reassurance that at least like they're dedicated to the education. I'm gonna say, I mean, I'm not just saying because I myself, when I actually took the test and I was studying for it, I was a little bit surprised that they didn't go in depth as to like some of the hormone replacement things or some of the methodologies I'm familiar with. But I will say, if someone is Menopause Society certified, they 100% are dedicated to women's midlife health. So all those primary prevention pieces that we were talking about, they're going to be well versed and hopefully kind of focused on their practice in that vein versus just like shooting you up with whatever they can sell you. I think there's two different ways. I don't know if that kind of helped answer, but
I have a question.
yeah.
Hi. So it seems that like your recommendation is that everybody should be doing HRT, over call it 40, 45, whatever, right?
Yes.
And I know that there's so much discussion about this. Mary Claire Haver, whatever, I've listened to her podcast and all these people, and it's like, why don't doctors know about this? Why aren't they putting this as part of their regular protocol? Why, I'm 44 years old. Like, why isn't my OBGYN saying like you should be doing this? And in fact, for me, and this is like a segue to a question. So like I am on a pill, birth control pill. I was on a different birth control pill. I was getting headaches, and my OBGYN was like, you can't be on an estrogen based pill. So I'm on a progesterone pill, which is fine. But when you talk about HRT, she was like, it's a contraindication. You can't have estrogen. And I was like, okay, so like, how is that ever going to work? So like, what do you do?
Yeah.
What do I do?
Yeah, no. So ready, this is such a common question. So I love that. Thanks for sharing that. So one of the things I will say, so the estrogen that she's talking about is the conjugated or a synthetic estrogen. It is not the bioidentical form. The other thing is this is where to me the education needs to happen even at the OBGYN and primary care level. So birth control, it is a hormone, but it's like a hormone on steroids. It is like the Hulk. So how birth control works is it literally binds to all the receptors and shuts off your ovaries. Like I'm going to sound a little crass, but it literally castrates a woman. So you're no longer able to make your own hormones, so you don't ovulate, we don't get pregnant, etc. Now, the other benefits that we've learned through using them throughout the decades is that it works really well for symptom management, right? Because it binds to those same receptors. The downside is you are going to get some of those benefits, but the fact that you took synthetic estrogen and you had headaches does not mean it's a contraindication for bioidentical. Now, again, there was two different forms. So there's transdermal, right? Or there's oral. For someone like you, like obviously you'd want to know your full health history and stuff like that. But if like, say, for example, you have a history of migraines and you're like, you know what, I really just don't want to take the risk at all. Patches, transdermal, completely safe for you, not contraindicated at all with that symptom, not at all.
Okay.
Yeah, to me, it's a little funny. And again, I'm not saying this as a scare thing, but it's the synthetic progesterone that's associated with a risk factor.
Interesting. Okay.
Yeah.
Thank you.
Yeah,
And
you're
I'm on
welcome.
your website, so you're only in whatever states are on your website. You can't cross state lines, so to speak.
I am, well, what state are you in?
Florida.
Where?
Florida.
Um, so interestingly, I am actually licensed in Florida, and someone just recently shared with me that yes, there's a loophole. I guess like I can practice in Florida, but I could probably follow up. I have not yet followed up because no one's really reached out or asked, but I could possibly.
Okay. All right. Well,
Um,
maybe I'll set up a consultation with you and then we can.
yeah, I would love that.
Awesome. Thank you.
Yeah, you're welcome. I don't know how many other people are on here, but obviously if anyone has any questions, please feel free to put them in the chat or chime in too. I'm happy to answer them.
Yeah, I actually have one. Hi, Danielle.
Hi.
So coincidentally enough, I have an appointment tomorrow with my friend on HRT. And the cool story about this is she was actually my primary care, and she left primary care to go get her menopause society certification and do this practice because she was getting so many questions from her patients and felt like she wasn't like couldn't answer them, couldn't get them the help that they needed. So
You have a great primary care provider.
excited. So this was super helpful to hear. I've been thinking about like, okay, what do I need to go to her with? So trying to get a handle and even list out symptoms because I'm like, oh yeah, like that happens to me. Oh, that happens to me. So I was wondering, do you have, kind of what do you think makes for a good initial consultation so I can go in there and like be prepared and be helpful?
Yes, totally. So one of the things I have, and let me see if I can find a link. It's a whole like downloadable, I guess like PDF or booklet to kind of help prepare for those visits. So one of the things I would say is having some of this information that you're already armed with, like synthetic versus bioidentical. I'm going to go on a massive assumption that if she's broken away, went for that certification, she's aware of that. Um, I would absolutely try and ask for some of those testings that we said prior, like some of those inflammatory markers like HSCRP.
And she did CRP, that was great. And I was able to run my blood work and do all that.
Great. Oh, did you get your blood work done already?
Yeah, yeah, sure.
Did you do the lipo A and ApoB?
I don't know if we did that. That didn't ring a bell to me, so I'm gonna have to check.
It's usually with the cholesterol, so it's either
Oh,
the
then we did. Yes, yes, we
yeah.
did.
Awesome. Awesome. She sounds like a good one. So yeah, so really kind of going in, maybe understanding too, like what your comfort is for risk as far as hormone replacement. So one of the things I will say, again, we talked about like the oral or sublingual versus transdermal. A lot of times, like if women are just like, I don't want any risk, intermediate or low, we just do transdermal estradiol. That is hands down the like the safest. There's no risk whatsoever with it. Oral progesterone is probably the best. A lot of times people will use like topical progesterone. It never gets the blood levels up high enough to kind of give you that endometrial protection. If you're still needing some form of contraception, that is something you can talk to her about, like whether you want to do like an IUD. No, you're like shaking.
I actually just went off the pill, and it's funny what Caroline said. I was on it for like almost 30 years, so I literally went off 2 months ago. So
Okay.
yeah,
Okay.
so
Yeah. So one of the
and that's cost me on its own.
Oh, yeah. So one of the biggest things when I have women, especially who have a long history of being on birth control, a very common thing that, I mean, I would, without seeing your labs, I would put a ton of money on this, that your SHBG, and I hope she tested that, is really high. So your sex hormone binding globulin, again, if we think about what birth control is, it's like your hormones on the Hulk. Your SHBG, I kind of explained like they're the buses in your body that put hormones on board and they transport it around and they have a great job, but they do it too well. So once those hormones are on the bus, it doesn't let it off to go do its thing at the cellular level. So what happens is when you have a really high SHBG and say no testosterone, you barely have any circulating to begin with, along with other hormones. So you kind of have to keep that in mind when you're dosing someone. Hopefully I would ask her if she's comfortable doing testosterone. A lot of times, some providers, and rightfully so, I do vet the compounding pharmacies I work with pretty strictly. There is a ton out there, and yes, is it like the Wild West? I'm sure it is. So some providers are not always comfortable prescribing to a compounding pharmacy. I prefer to do that, especially when doing testosterone, but there are the male versions like the androgel that is a viable option. Again, like I said, there's the downsides of like where you can apply it. It would be more to your skin. It's alcohol based and just harder.
Mentioned using compound pharmacy, so I think it sounds like she's
Oh,
able.
perfect. She did say that. Yeah, that's awesome.
Yeah, yeah.
So this is another thing. I don't, this is to me, again, I'm like particular about what I put in my body. And when I learned this, it just made me feel so sad. But progesterone from the commercial pharmacies it's usually in peanut oil, which is a great base or delivery system. You do want some fat when you're taking oral progesterone because it does help with the absorption. But that being said, they get their peanut oil from the cheapest source possible. So conventional farming uses peanuts in farming in their soil to absorb pesticides, and then they sell those peanuts for other byproducts. I know. So when I learned that, and I was like, cool. So I buy organic berries that are just going to mold in my fridge half the time. So then I'm just taking a pill every night, just like with a ton of glyphosate. I was like, awesome. So I personally do now really strongly encourage women to try and get their progesterone from a compounding pharmacy to kind of avoid that. Obviously, sometimes financially that makes more sense. And I'm not completely dissing that. Something is better than nothing. We don't have to always like, don't let good be the enemy of perfect. But at the same time, that was just like a personal me. So if she does work with a compounding pharmacy, I would 100% ask her if that's a viable option, if it makes sense for you.
Great, thank you.
Yeah, you're welcome. Anyone else have any other questions?
Christine, will you report back after your appointment? I'm just
Definitely.
curious. I'm curious.
Absolutely.
She
Yeah.
sounds
Yeah, I'm like, I want to know.
Yeah.
I'll tell everyone.
I know. I get so excited for people. I really do. Like when I meet with patients, and especially some who have been like, dismissed. I think to me, that's the hardest part is like, it's heartbreaking to hear women get dismissed. And one of the things, and I used to say this in primary care too, you know your body best. I know you for 5-10 minutes at a time for like not even a sprinkle of time in your life existence. You know your body best. And if I can tell women one thing, please do not stop advocating. You know what's right, you know what feels right. It may take a lot of shopping around, but please don't feel like if you're being dismissed, you're being dismissed. You're not going crazy. It's not in your head. It's not in your head.
I was just saying this to a client, like, think about that. Like, you're going to your doctor once a year for 5 minutes, maybe 10 minutes. And like, how do they know all the things about your body? I mean, like, yes, they're educated and they can put some pretty good guesses out there. But at the end of the day, like, you know your body best. And it's so
Totally.
unfortunate that like, it's few and far between that practitioners and doctors are doing it the right way. It's always like a surprise, and they're like going
Yeah.
to compounding pharmacies and all that. So anyways, I'm very excited for you, Christine, and I'm just
Me
glad
too.
you exist, Danielle, and you are out there spreading this message.
No,
So,
thanks.
it's needed. It's really needed.
Thank you.
Yeah, I wanted to add that I had a similar experience that you described, Danielle. I went to my primary care doctor, and she was basically like, "Do you want to be put on mood enhancers?" And I had like this list of symptoms that I was struggling with, that I continue to struggle with. So I do have an appointment to see my gynecologist later this month, and I'm hoping that she's open to this. I don't really know. I guess I'll find out when I get there. So, but I wanted, Christine, are you in Massachusetts?
Me?
Yeah.
Yeah.
Okay.
I'm actually not far from I'm on the South Shore, so
Yeah.
I'm in
Okay.
Boston,
Yeah.
but I live in Pembroke, so
Yep.
Okay.
We got a lot
Oh,
of
nice.
local ladies.
yeah.
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 Oh, Christine, who are you seeing then?
Her name is Dr. Gina Zarella.
Oh, I
She's
don't
in
know.
the Brigham. She literally just left the Brigham like within a month. So this is the start of her but like I said, she's
Nice.
my primary, and
Awesome.
I loved her like as a person. So I'm fired
That's
up.
awesome. That's huge.
Yeah.
That's funny. Anna, are you on the South Shore too?
I am. I'm in Brockton.
Nice.
Oh, nice. Awesome. Okay.
Yeah,
Yes,
and I'm
like
happy
you,
to share.
Danielle.
I was gonna say I'm on the South Shore.
I can't get my camera to turn on because I'm using my iPad. I'm like, I can't
Okay.
figure this
No
out.
worries. No worries.
Yeah, but it's like progesterone can help with the sleep.
Yes.
Makes a
Yes,
world
I
of
need
difference.
that.
Oh my gosh, it's game changing. Game changing. I
Really
actually ran out one time. Like just I wasn't paying attention to my own refills. And I remember being like, it was a week of like torture. And I was like, wow, like if this doesn't show me even like some of the pain or like the brain fog, all of it, I was just like, I have like my back stock now because I will never be without it.
I got a lot too.
Yeah. Awesome. Any
Yeah,
other questions?
no, I was just saying, I can't wait. I've talked to some of my friends and ladies that I work with, and I'm like, why have I waited so long to do this?
I know. And it's so sad because I feel like it's just like what Christine was saying, like why aren't doctors doing this? I am hoping this is the dialogue's changing and education will be out there more frequently. But yeah, it's just something that I think again, I was in the mindset too. Like I was in that primary care world of where hormones were harmful. So we just, I will say I'll give practitioners and doctors the benefit of the doubt. We don't want to do harm to our patients, obviously, like that's our number one thing. But when it's like drilled into your head that hormones will hurt you or give you cancer. Full disclosure, I was recently fired by my OBGYN because she told me I was going to give myself cancer. So I was like, okay, thank you. We're probably not a good fit.
Wow.
So,
Yeah.
but yeah. Well, I
Yeah.
hope you have a good experience, Anna. I do. I wish you luck.
Report back. Report
Yeah,
back.
I will.
absolutely.
Thank you. Thank you.
Yeah. Well,
This was a
thank
great call.
you,
Thank you.
Danielle. This was awesome. And I don't know if I put Danielle's info in the group, but I'll put it in the Fit and Fueled group. And then if you're a one-on-one client watching this back, we can always put you in touch. All the coaches have Danielle's info now, so they can refer out. But yeah, just thank you so much for being here. And yeah, just letting ladies know that this is a good thing for their health, not a scary thing for their health. So
Totally, totally. And I did just share my information in the chat. Obviously, anyone who's listening to the recording, feel free to reach out anytime. I'm always happy to do like when a free consult. You can schedule that on my website. I do it all the time. Even if you're not in my state, I'm happy to kind of direct you or at least make you feel heard. Okay.
Yay. Awesome. Cool.
Awesome.
Thank
Thank you so much
you.
for having me.
Thank you.
Bye, guys.
Bye.
Thank you.
Bye.